My question is if there's a recommendation for how many patient samples you use to test your pre and post when you're looking at your measurement, your analysis.
For the recovery phase?
Yes.
Yeah, so.
No, not
Not mine. Dr. Miller?
I'm sorry? Yeah, lot to lot.
Oh.
Okay.
That's
So
what I meant.
Yeah, there's a CLSI document that addresses this and provides some statistics around using between, I think it's somewhere between a minimum of, if I remember, I don't remember exactly, but it's like 3 to 5 is kind of the minimum number. And it sometimes is convenient to use about 10 just to make it a lot easier to analyze the data when you're finished.
Yeah, what's the document? CLSI,
I don't remember the number.
EV26 or something, reagent lot change document. Yeah, and it goes in quite a bit of detail about emphasizing the fact that you need to test patient samples to determine whether it's a reagent lot problem. You can't use QCs, as Dr. Miller has pointed out. And then recognizing that this occurs often, frequently, there's a number of tables and things in there that suggest how many patient samples need to be tested with the old and new reagent lot in order to assure that you're detecting medically important changes. And that it's done in such a way that the statistic, the computation is very straightforward and the numbers tend to be pretty small, the requirements. But that's all in that document.
Good morning. Thanks for really excellent talks. You talked a lot about large volume kind of testing. I'm wondering if you have any suggestions, recommendations about evaluation of quality control used for small point of care testing devices that are only running QC on a monthly basis. How do you look at those values and get anything out of them?
Point of care. I'll jump in while they're trying to decide. Point of care is a very interesting problem and one that we are talking about quite a bit in Bio-Rad in terms of how to think about quality control and quality control strategies. There are enough differences in the point of care situation so that while the concepts and the principles apply, the actual implementation strategies really need to differ. And it has to do with, again, point of care is kind of tough. I mean, officially, point of care just means that you're testing near the point of care. It could be the same kind of instrument that's used in the laboratory, I suspect. But typically, when I talk to people about point of care, they tend to think about unit use type devices, a device where you have some part maybe that's a reader that's reusable, but then there are cartridges that are single use. And then the idea being that if a cartridge is bad, that doesn't say anything necessarily about the next cartridge. So most of the work that I've been doing in that area or thinking about has to do with how do you really think about where out-of-control conditions or test system failures can occur in a point-of-care environment, and how do you design a QC strategy, not in terms of rules, but in terms of frequency and location of testing to address those. And so you could potentially have a problem with your cartridges, the way they're stored, the way they've been transported. So the idea being that at some point in time, a cartridge is bad and you suspect that all the other cartridges that were maintained or stored the same way might be bad also. You have problems potentially with the reader, a particular individual reader. You have possibly problems with a user. And so how do you set up a QC strategy that has a reasonable opportunity to test for all three of those potential sources of problems? So a schedule that's testing the lot of cartridges at a rate so that if something goes on, it's not too long before you detect it. Something that's testing a reader at a rate so that if something goes on, it's not too long before you detect it. And something that's testing the user. So the scheduling of it, I think, is a little more complicated, a little more sophisticated than would be for something in the laboratory. And there's no, I haven't formulated what I consider real good guidelines on it yet, but that's at least the way I'm thinking about the problem. I don't do it, though, day in and day out, so I don't know what actual things people are doing in the labs. I know that the idea of having to test every cartridge every day kind of idea is kind of crazy, and I'm not so sure that is really required, or every reader every day.
Just a quick comment. C24 is really designed around statistical process control. The question really, EP23 from CLSI is a document that addresses risk-based assessment and includes consideration of all of the risk mitigation strategies, which would include things like built-in control processes, monitoring systems that may occur in an instrument, as well as the concepts of how frequently the operator training and competency get assessed. So it gives a bigger picture of the completed testing environment and has a lot of good guidance around applicable, in particular, to the point of care setting.
Dr. Nicola, sorry the question, but I'm interested. How the frequency in your lab that you observe the quality control is out of control per year or per month, and what is the parameter that is very difficult to maintain inside the control in your experience?
Yeah.
Can you repeat the question? We couldn't really hear very clearly.
In your lab, how is the frequency that you observe some analysis that's out of control in your experience? I don't know if you have this number. And what is the parameter that is too difficult to maintain inside the control in clinical chemistry, for example?
I don't understand. Oh, no.
Yes.
Okay. Oh, thank you. There's static. It was hard for us to understand. So frequency of failures in my lab, I can't tell you percent of results. I can tell you that what we monitor is how many patient samples we had to retest and how many we have to revise. Our revision rate is very low. We're more like that lab A. So we have about a 4 to 7% revision rate of retested samples. That probably means that I can loosen up some QC. I'm scared to do that. I'd rather be on that end of the spectrum. As far as like everyone, we have some assays that are just a little bit more of a pain than others. It tends to be, but it's the high volume testing, so it's just some that tend to be a little bit more problematic. So those retests are usually just split between maybe 3 to 5 analytes in a month. And sometimes the same, but sometimes different analytes. We probably do several hundred patient retests, but we get about 10,000 specimens a day in my laboratory. So it's a low retest rate in the big picture.
Thank you for the talk. Dr. Baumann, when you say you retest until the last good QC, if your QC failure is a 2.2S, does that mean you're going back 2 analytical runs? That's my question for you. And Dr. Miller, if we switch QC materials, what do we need to do to ensure that the QC materials are actually mirroring patient samples, the purpose of QC? And then lastly, what I also see on Levy-Jennings charts is not a Gaussian distribution. I fairly frequently see most data points between plus and minus 1. So they have the QC chart set up incorrectly, which will affect their decisions and their corrective action. So how do we work with a single data population versus cumulative for the Levy-Jennings chart? Thank you.
Okay, I'll take the first question, which was if it's a 2.2S failure, are you going back to QC measurements? I'm so glad you asked that question because I can advertise a paper by Dr. Parvin that was published. So we use a rule that's called the 1.2S repeat. When we get a 1.2S warning, we immediately run the QC again. so that we don't have that interval of time where we're testing and it may have actually been a real failure. Dr. Parvin's paper on this showed that actually the error detection of a 1-2S repeat is similar to a 1-2S rule, but the false rejection rate is similar to that of a 1-3S. So in my laboratory, I love that rule, and a lot of labs do this. I think we've been told that it's not good practice. I actually think it reduces the amount of time where you may have been out of control and you don't know it. And Dr. Parvin's paper actually supports what a lot of labs have been doing for a long time.
So the answer to your second question, which as I understand it is when you look at your Levy-Jennings charts, you observe that most of your values seem to be hovering between ±1.
When I go out to other laboratories, that's the typical Levy-Jennings chart
Right.
I see.
Yeah, and you have to, there's a couple of things to consider here. The first thing to consider is the standard deviations might be incorrect, and they might be excessively large based on, for whatever reason. The other thing to consider is that you have to consider the length of time you're examining. So if you're looking at a monthly chart, it's not uncommon to see the values as you described, but if you look at a year, you should see them moving around because the sources of variability are going to be different from month to month. So a recalibration event may cause a small shift, but it may be irrelevant from a medical interpretation point of view, and so things will be like this and like this and like this. So short time intervals will look more compact, if that's the right word, on a Levy-Jennings chart than a big picture. So those are just two considerations. And I forgot the first question.
When we go into bringing in new QC material,
When we bring in new QC material, what do we need to do to even ensure that that QC material mirrors patients?
Well, that's really a great question because QC material is designed by its manufacturer to closely simulate patient characteristics. But the reality is it's a manufactured product that has usually supplements added to achieve different concentration levels. It has stabilizers added, so it has an acceptable shelf life. So that's why we have the commutability issue. So it's really not, in my opinion, the matrix should reasonably well simulate a patient matrix, but it's not that important. The important thing is to establish a suitable target value that represents performance on a given instrument system or instrument measurement procedure, and then use that as a tracking device. QC material is not designed to be used to answer the question, am I getting an accurate answer relative to a reference method? It's really designed to answer the question, is my performance staying consistent over extended periods of time?
Two more questions.
So I have an interest in kind of the opposite end of the spectrum from point of care testing, which is with mass spectrometry testing, where we have a ton of information about our result, a lot of metadata to say how is the instrument performing, what is the nature of that result, is it correct? And we often handle that in a kind of primitive manner, like it's okay, it's not okay. But often when you track that information over the long term, it tells you something about the nature of the measurement procedure and whether perhaps you could detect a failure before your QC fails or tell you that something's happening. Are any of you looking, if we could process that information electronically, send it across the interface and have it, say, tracked in the same way that we do QC, I think that it could add a lot of value. Are any of you doing any of that?
Yeah, I assume you're talking about the general concept of monitoring patient data to pick up trends? No, okay.
This is what would be.
You don't just have a number, you have a lot of other information about the nature.
This is a huge field in industrial quality control. It's engineering process control in a sense. It's monitoring all those other things in the instrument in real time that can suggest what the performance of the instrument is. And actually, if you do it well, you can detect and they have feedback loops. They detect and correct problems before it becomes a problem that will be detected by QC. More power to any instrument manufacturer out there that's doing all that stuff. Do you guys have instruments like that? But it would be kind of like things that are monitoring, flow and temperature and all kinds of stuff like that.
Yeah. In the automated instrument arena, they're starting to do that where they're gathering data directly, but I haven't seen anything that was the push. The buy-in was, well, maybe we can find other things that go wrong before QC is out of control. I haven't heard of anything really solid coming from that, but it's in its early phases.
Last question.
Oh, my question is, for example, on assay chemistry for Bio-Rad, it's an assay. But when you get that lot, they already have some pure data already. Do you consider as an assay value, assay material, using the data?
I'm the wrong guy to ask that question. Does someone in the room have an answer to that question?
If I understand the question correctly, you're talking about the Bio-Rad offers a program where laboratories submit data and they calculate peer group target
They are
value.
on assay value. But when you
Unassay,
but on assay chemistry the material, QC material. But when you receive it maybe you run it 2 months behind. So when you look at the data, that lot, they already have data in there. So do you just verify them, or do you still have to go for the routine data?
I think
And what I mean is you have to run 20 data, or 10 data, or 5 data, because already you have the assay value. Console has the assay value already.
So I'm sure. So Bio-Rad offers what they call assay control materials. They have an assigned value.
he's talking about unassayed.
And then they have unassayed, where we don't give you a number. In either case, a lab, and what C24 will say is, irrespective of whether or not the control material comes with an assigned value, in your laboratory, you are required to establish a target value for yourself. And everything that Dr. Miller talked about would apply for assayed or unassayed QC materials in the same way. So.
Yeah, and we use some unassayed controls, some assayed. We don't treat them any differently. That 20 days of data collection or whatever period, a minimum of 20 days, whatever period would really encompass all of the variables that Dr. Miller talked about is what we would use to establish our mean.
Okay, so
Yes.
just to clarify, the next version of C24 recommends a minimum
Sorry,
of 10,
10.
10 measurements.
Right, yeah.
Because 10 is sufficient to establish a reasonably reliable target value. And then you can adjust it when you get 30 or 50 or some other larger number to give you a bit more confidence.
All the material analyzed for 20 data, you're talking financial impact.
Yeah.
I just think that the target value, if your target value isn't correct for your own laboratory, you're,
Look at it and see what is the target value. As long as your SE is even lower than the peer group.
Okay, I think I'm beginning to understand your question. So the recommendation is after a period of time, let's call it 30 days or 60 days, it's typically recommended to make an adjustment to the target value because you've now accumulated more data to give you a more robust target value, and the sampling period has included more contributors to the small variability you're going to see from day to day. So the target value would better represent the center of your expected distribution if you recompute it after a period of time.
I thank you all for being here early and for staying through the entire time, and go forth and do good quality control. Thank you.